my line can only go one way. It's specifically fitted so that it can only go like this. If you try to put it in upside down, it won't fit. And then once we have connection, you'll see that my monitor lights up with the flow. So we now have a red tracing waveform, and it's going from 0.75s at the mid and 150s at the top, and it says ABP, and the reason for that is because it's referring to arterial blood pressure. Now, can we monitor a CVP? Actually, we can on the ABP line. The other line, if we disconnect, is now the bottom yellow line, and it's got a pressure of 0 to 20 PAP for the pulmonary artery pressure. So this can give us our pulmonary artery waveform, as well as if we go to inflate our bulb, we can get a wedge off of this as well. But the thing to make it to notice of the difference here is that it's 0 to 20 versus 0 to 150. All right, so I'm going to bring that in, let you guys see that. All right, so 0 to 20 versus 0 to 150. So the point is that if I'm going to be monitoring a CVP, do I want it here or do I want it here? Now, our normal CVP is going to be somewhere between 2 to 6 millimeters mercury, and it's a low amplitude rolling waveform. So preferentially, I want to use this one, 0 to 20, because the scale is better. If I'm actually monitoring an arterial line, which is giving me at the high point my systolic pressure, at the low point my diastolic pressure, then I do want the arterial blood pressure. Now, both are scalable, but this one's going to match better for my CVP, and I'm obviously going to be monitoring CVP probably pretty frequently. Okay, so the very next thing that we need to do is we have our pressure bag up, we have confirmed our pressure, we have all the air is out of our line. So this half of the line is set at 300 millimeters of mercury. What we need to figure out is we got to turn the valve off to the patient. And we need to allow the transducer to know where we are for atmospheric pressure. This machine doesn't know the difference whether or not we're sitting at sea level versus sitting, at a hospital in the Rockies at 10,000 feet. It doesn't know the difference, so we actually need to zero it. So what we're going to do is this button here says zero pressure. We turn it off to the patient, turn our three-way stopcock off to the patient, and we zero our pressure. So zero we're currently on our PAP. So we're zeroing our PAP, yes. And now it says PAP zeroed, and it gives us a timestamp. All right, so once it's zeroed, we can now proceed on to the fast flush test. So if we do the fast flush test, what we do is we pull the pigtail, and then we release the pigtail. Once we release the pigtail, you're going to see that it's going to notice the pressure change. So you see the waveform goes super high square, and then it has a couple bounces. And what we want is we want it to have about 3 nice tight bounces, and then go right back to baseline again. That's what we want. If it has a whole bunch of bounces across the line, like 7 to 10, that means that the line is too dynamic, and we're going to discuss why that is the case. If it has no bounces at all, if we do the pull, we get a square, and we release, and we get 0 bounce, that means there's too much cushioning in the line. It's underdynamic. So there's overdamped and underdamped when it comes to invasive pressure monitoring. The best way that I can explain this, which was taught to me, is the fact that if you think about what this is doing is, you put your fingers on someone's radial pulse, and what you're feeling is the pulse wave from the heart, squeeze, and then, coming down, and you feel the pulse wave. Well, this is just connecting into a catheter. Can be actually a radial artery. Could be at the, the central line, right into the right atrium. But at the radial artery for like a pulmonary, or for a radial, for an art line, This is just an extension of the pressure wave, whether we're monitoring the venous system or the arterial system. This is just an extension of the pressure wave. So until it gets to right here, and then it's picking up the variance, and it's deflecting and showing us that variance on the screen for us to be able to read it and be able to see the quantifiable values. So we know whether or not the CVP is way low or way high. Same thing with our art line, same thing with our wedge pressure. All this data is available to us. So what it's showing is the difference, and we're looking at the waveform of the difference. Well, we want to have an accurate depiction. If you were to take a tennis ball and throw it on the floor and bounce it up to your friend who's 15 feet away, if you had a hard concrete floor, then that's actually going to bounce real tight. And you throw it at medium strength, and it's going to bounce over your partner's head. So there's not enough give on the floor. If, however, between the two of us there was a water bed and there was a whole lot of cushion there, and I throw the same ball with the same strength, it's going to absorb all of the pressure, and it's not even going to bounce back up. It's just going to hit once and then roll. So that's not enough of a give back. So instead, if we have just kind of like a nice carpeted floor, where we take the ball, we throw it down, it hits, it bounces up, and my partner grabs it right away. That's aligned with the correct amount of a dynamic line. So the one where there's too much give, too much absorption, what things can cause too much absorption? Well, one of the things that can cause too much absorption of being able to see the pressure variance is if this side is under pressure. So then we come over here and we look and we're like, oh, we lost pressure here. So therefore we have an over-dampened line, too much dampening on the line. The other thing that can cause too much dampening is if all of our multiple connections, our screw-on multiple connections for the actual line, have become loose and they're leaking a little bit. Okay, so our connection here, our connection here. If they're loose, that can also create too much dampening. The main culprit of too much dampening are all these little air bubbles that could be in there, because instead of having a nice continuous extension of your own pulse wave, instead every time it hits a big cushion of air, it's cushioning it, cushioning it, cushioning it, cushioning it, and the end result is you have an over-dampened system that's not portraying the pulse wave correctly. As far as a hyper dynamic line, so an under-damping, not enough damping, is going to be, the main culprit is going to be over-pressuring of your pressure bag, so you look and you're in the red. Okay? Now, without squeezing it, how could we suddenly become in the red? Well, the easiest answer for that is going to be in flight medicine. We'll go up in elevation. This is full of air. As we go up in elevation, Boyle's law says this expands. As it expands, it puts more pressure on the bag. And now, this goes hyperpressure, and now we're in the red. So, when we get up to altitude, whether even if we're on a ground system and we drive up over the mountains to get to our primary center, we go up. We notice we're in the red, we need to decrease in our red, but we've also changed our atmospheric pressure, so we need to re-zero our line on the machine to let it know that we've now climbed or descended. So every time you do a significant change in altitude, whether you're on the ground unit or on a medevac aviation unit, you're going to need to check the pressure and re-zero your line. So the other thing that can create not enough damping, an underdamped line, the last thing is simply going to be if you're monitoring an art line on the radial, but the tip of the catheter is right up against the edge of the of your vessel, that can also make it too tight. It's not giving enough even flow back and forth to be able to pick up the pulse wave. So those things can create an overdamped line or an underdamped line. And then that's pretty much it. We're monitoring our system. If we notice that the amplitude of our line keeps going down, 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 that means that we're losing pressure somewhere. So we're getting too much damping. And we're going to go back. We're going to check our connections. We're going to see if we have any air in the line that's kind of snuck in there. Maybe we took the bag off. But if you flooded the line completely, then when you go to move your patient, they can come off of the IV pole. They can come off the IV pole, and this bag can sit at the patient's leg, because even if it's upside down, it's not going to flow air into your line. So that's why we take those precautions and those measures. So That's pretty much it for invasive pressure monitoring. Best of luck in taking care of your patients. And until we talk again, love, protect, and help.